Back, everyone. I hope you had a good lunch. So in this next session, over the next hour, we're going to explore the different approaches around the world to health and professional regulation. And to get us in the mood for that, I'd like to invite Carrie Yam, who's a health researcher and statistical expert at the Chinese University of Hong Kong, to give us a short presentation.
Good morning. First of all, thanks for the conference organizer in inviting us to join this panel discussion to share with you the findings of our study. And this study is commissioned by the Hong Kong government on a review of the regulatory framework for the healthcare professions. And the first part of our study is an international experience review, and which we studied 12 jurisdictions here, including the Western and the Asian Pacific regions. And we adapt a 4P analytical framework to study the role and contributions of different stakeholders, including the policymakers, the services providers who are the employers of the health professions, and then the professionals, also the patients and public towards the health professional regulations. And the healthcare system context or any major historical event or incidents are also studied in this research. So here come our observations. We have 10 key messages here. The first one will be the reform of regulations is to protect patients and improve quality of care. And can you help me to kick the arrow? Many jurisdictions are undergoing regulatory reforms from time to time, and this is a continuing evolutionary process which is affected by the changing public expectations, in which the public wants more participate in the healthcare practice and governance, and there's also greater desires for transparency and accountability. And most often, the reform or changes in the regulations are triggered by the scandal or because of the political or the professional interests. And one of the strategies in UK you can heard of is the Dr. Shipman event, and he is a GP in the community who have killed over 250 patients in his practice. So it leads to the reform in the structure in the General Medical Council. So the main aim of the regulations is increasingly seen as to protect patients, to ensure the patient safety, and improving the quality of care. So back, please. And in order to reform or change the structures, legislative changes are required. So arrow, please. And one example of the legislative change will be the creations of the umbrella legislations to ensure the consistency in the regulation of professions. In the table here, you can see that some jurisdictions, say Australia, New Zealand, or Canada and Finland, they have a single act for all professions. But in other jurisdictions, say in UK, Singapore, or Hong Kong, they don't have a single act for for all professions, but they are having it for some professions, say the allied health professions. So arrow, please. And apart from the umbrella legislations, we also have the umbrella, or you can call it overarching organizations, are being created to ensure to bring the common principle of governance, or to bring the common values or process across the jurisdictions. And examples are including the professional standard authority for health and social care in UK, or in Australia they also have one which is called the Australian Health Practitioner Regulation Agency. With regard to the model of regulations, we also found that there are a trend moving towards self-regulations in partnership with other stakeholders, which include the public or the government or service providers in the healthcare system for more openness or accountability. And with respect to the partnerships with the patients or the public, we found lay representations is becoming the norm. So arrow, please. And there is a global trend to increase the involvement of the lay people on the medical board or councils or the review panels inquiries. And the table here show you the memberships of the medical council or board. And I just want to highlight the second column here, which is the percentage of the lay representations in the medical councils. And you can find that UK has the largest number of lay representations, which is at 50%. Australia, New Zealand have around over 30%. Canada and USA, they have different percentage of lay members depending on their states or the province regulations. And for some jurisdictions, say Singapore, Malaysia, they don't have any lay memberships, but instead they have the government to be in the regulations as a strong government oversight. So you can find that in Singapore, they have the Director of Medical Services being the registrar, and the Malaysia, they have the Director of General as the ex-official president. So arrow back, please. And then I'm going to this point 6, which is in addition to the medical regulators, we also have other regulators, say the institutional regulators or the health system regulators. Say the care quality commissions in UK will be one of the health system regulators. And then the 7th point will be the compulsory continuous professional development. Can I go to the arrow? And nowadays, the doctors are required to demonstrate that they have an up-to-date standard because of the advanced technologies and also the biomedical knowledge. So there's an increasing trend of the compulsory CPD for all health professionals to maintain their professional competency. The table here shows that in the jurisdiction that we have studied, nearly all of them have the compulsory CPD. But in Hong Kong, we only have it for the specialists only, while as in Malaysia, they don't have this at this moment. So maybe back, please. And the number 8 point will be there is an emerging emphasis on detecting and dealing early with the poor performance for the improvement of the quality of care. And so you can find that there are many different approaches of performance assessment is being implemented. So let's say there's revalidations in UK just start 2 years ago, and also there are recertifications in United States. And then I come to the point 9, which is I want to highlight that greater separation of role is occurring. Because to reduce the conflict of interest, then the investigatory or the disciplinary functions in the regulators are increasingly being separate or organized independent of each other. So, for example, in UK, the medical petitioner tribunal services have been set up to provide the hearing services that is fully independent, and then this is also separate from the investigatory role of this General Medical Council. And in addition, there are also other separated accredited bodies to accreditate the educational providers or training, like the one in Australia, Canada, or US. So now I come to the last point, which is about the overseas trained doctors. So can you go to the arrow? And there are many different criteria for employing the overseas trained doctors, which normally include the language proficiency assessment. In a few jurisdictions, they have the compulsory licensing or qualifying examinations, say in US and in Hong Kong. And then other jurisdictions might have a recognized list of qualified overseas institutions for the overseas trained doctors. Say in Singapore, they have over 150 institutions in 28 jurisdictions. In Malaysia, they have even more, say over 350 institutions in about 36 jurisdictions. And though they do not have the qualified examinations or internship, but they still need some form of professional assessment, which might be require a period of supervised training before they can working in the health system independently. The last point here, I just want to highlight, even within the same jurisdictions, they also have mixed mechanism in dealing with the overseas trained doctors. Say in Australia, you know, there are many different pathways for the overseas trained doctor. Say they have the competent authority pathway, which is for some jurisdiction they recognize as competent authority, say the UK, and then the New Zealand, and then they do not require the examinations. But they also have other specialist pathway with the specialists and also the standard pathway. So in conclusions, we found there are many similarities and differences between the professionals or across the jurisdictions in how the people are being regulated and who they're regulated and by whom. And regulation of profession actually is a very hot topic across the jurisdictions for a lot of reasons, say because of political reasons, financial, legal, professional, and also concern about the quality. And the regulation often is tied in with the healthcare reform. And there is also a growing global network among those who are being involved in reviewing and also in changing the regulatory process. And so, you know, it is a rapidly changing terrain, and so it opens us for many discussions for improvement. Lastly, I just want to highlight overall from our review, there is a trend moving towards regulations which is in partnership with different stakeholders. In particular, it is with a greater involvement of the public. So this is the end of my presentation. Thank you.
Carrie, thank you very much indeed. Well, let's do a little bit of voting before I get our panel up. So we've got 4 questions for you. The first one, if sometimes there'll be more than one applies, but if you can only vote once, what model of regulation is in operation in your country? So choose one option: professional self-regulation, government-led regulation, independent regulation, or none of the above. So if you could vote, please. Okay, and if we could bring up the result. Everybody voted? Okay, so interestingly, it's roughly a third professional self-regulation, a third government-led, and a third independent regulation. And the next question: what proportion of your council or equivalent is made up of lay, non-medical professional or patient members? A, 0, B, less than 25%, C, 25 to 50%, D, 50%, E, more than 50%. If you can vote on that, please. And if we could have the result. Okay, so, well, again, quite a spread, but the most common being 25 to 50%. But interestingly, 1 in 5 of you, there's no lay involvement at all. And the next question: does your country have multi-professional regulation? A, no, single professional regulation only. B, some, multi-professional regulation for some but not all health professions. C, yes, one body or piece of legislation covering all health professions. Or D, maybe, multi-professional regulation currently under consideration. Now, you can only vote for one of those, I'm afraid. And if you could do that. Right, okay, we've got a problem with the technology on that one. So we'll come back and do that one later on. So some interesting results there, though, from that. If I could now invite our panel to come up. If I could start, where is my panel? Yes, Professor Sir Peter Rubin, Chair of the General Medical Council, Professor Frank Montgomery, who's President of the German Medical Association, Professor Sian Griffiths, among our many roles, is Emeritus Professor at the Chinese University of Hong Kong, and Elsie Smith, who's Director General of the Danish Health and Medicines Authority. Now, what I'm going to do is I'm going to spend a couple of minutes with each of them in turn, and then open the discussion out, and then I'll open it to the floor. So I very much want your involvement in this, but I think if we just start by getting a very brief picture of how the profession is regulated in each of the countries that they can talk about, then it will be helpful. So, Peter, if I can start with you, a simple, if you would, upsum of medical regulation as it stands now in the UK.
Thanks very much. Can you all hear me? Yep. No, I thought...
yes.
Yes, okay, great stuff.
Now.
We're the independent regulator of the medical profession. We're funded by the medical profession, and I'm not accountable to the Secretary of State, nor am I dependent on taxpayers' money. That gives us our independence. At the heart of what we do is we maintain a medical register to distinguish the qualified from the unqualified, and everything we do feeds into that register. We determine the outcomes of medical education, and we quality assure that, to determine what standards need to be achieved to get onto the register, and to progress through different standards, different stages of the register. We determine the professional standards to which doctors should practice in order to stay on the register, and Parliament gives us extensive legal powers to remove from the register or to put conditions on practice of those doctors who fall below those standards. The GMC is overseen by a council which is comprised of 12 people, 6 of whom are doctors and 6 of whom are lay.
Okay, and your role has expanded and changed a lot in recent years. Can you just talk about the extra elements that have come in recent years?
The GMC has changed out of all recognition in the last 11 or 12 years. For example, the council has gone from 104 to 12, which is quite a substantial change. We have separated out our adjudication function, for example. And so there's now, as Carrie mentioned, the Medical Practitioner Tribunal Service, overseen by a retired judge. The main driver for that, as Carrie said, some of it was Shipman, some of it was the Bristol heart scandal, but actually the way we did things was not compatible with Article 6 of the Human Rights Act, which basically says no one should be a judge in their own cause. So there had to be change. We've also introduced revalidation, which is meant to be prospective, is meant to help to identify at an early stage those doctors who need support, rather than doing what traditionally regulators have done, which is to be reactive and wait for a problem to be brought to us.
And do you see that direction of travel concentrating more on preventing problems rather than simply being there to pick up the pieces and be in judgment when things go wrong?
Absolutely. Prevention has to be better than cure. And so there's so much evidence that the earlier you identify a problem, whether it is in clinical performance or whether it's in health, the earlier you identify it, the more likely it is that A, you will protect the public, and B, you will be able to remediate that doctor.
Frank, if I can turn to you now. In Germany, how is the system of conduct regulation managed there?
I feel a little bit like a pink elephant because everything is so different in our country. And I found very little in your presentation what applies to my country. We rely on a system of subsidiarity, which is from the old Prussian times. And we're a federal state. That means we have 16 chambers. The government gives the license to practice. Every physician has to be a compulsory member of the chamber in his region, one of the 16 chambers, and they supervise the professional conduct. We can, if we find problems in behavior of physicians, we have a professional body, a court, that sits over the questions and decides. We can fine a physician. We can ask the government to suspend his license, but we can neither give a partial suspension of the license, nor can we suspend the license ourselves. And we find that in very many cases, when the professional body of the profession asks the government to suspend the license, the government won't do it because they are afraid of interfering with the life career of a physician.
Now, Frank, when you've held a conduct hearing and you decide that you want to discipline a doctor, can you do what happens in many other countries? Can you state particular terms of practice? For example, a doctor can't do certain types of surgery.
No. We can fine him, but we cannot suspend certain fields of medicine. For instance, a heart transplant surgeon who could still do very well do appendectomies, no, we can only take his license or leave his license. There is nothing in between. So this is a big problem because it always means the destruction of a career if you go to that stage. And the government doesn't follow us in in taking the license when it could be necessary.
That must be incredibly frustrating, because you could have...
Yes, it is.
You feel sometimes compelled to ask for a doctor to be struck off who could actually do very useful things.
I call my system sometimes that is fighting with a wet paper sword, because you have a very good court, you come to very good conclusions, but it is very difficult to execute them towards the persons in the end. So it is a complicated system, and I'm quite surprised, actually, and I mean, you understand that in a positive way, surprised that we have so few scandals or so little scandals in our country, and we are sometimes worried when we hear that of scandals which happen in other countries, if I may say this with a slight look to my left side.
Well, so you've got problems, but you wouldn't like to jump into bed with the UK system and give up self-regulation?
Definitely not. We are the whole German system since Prussian times relies on self-regulation, and in our chamber system we do much more than only regulating professional conduct. We also regulate professional development. We regulate the training of specialists, which is done by other bodies in other countries. So we are the sort of the overarching, overall regulator of the whole profession, and I think we do believe in that system. And I think the standard of German physicians is, well, I'm not trying to sell them to you, but I say it's quite good.
Okay. Sian, can I talk to you then about Hong Kong? We saw that research that Carrie did. How is regulation carried out there?
Well, just as Frank was talking about Prussian history, just to remind you, of course, Hong Kong was a colony. So much of what Peter started with is where Hong Kong possibly still is and is still evolving from. So we haven't moved towards revalidation. We, as Carrie showed on the slides, we don't even have compulsory CPD, which means that once a doctor is licensed, they're licensed, and then there's no checking on standards by an organisation. So Hong Kong is and the reason we did the work was the government are actually interested in which way to go, which is why we looked across all the different countries we looked across. And so Hong Kong specialists are regulated. The Hong Kong Academy of Medicine plays a big role, working alongside the Hong Kong Medical Council. But our Medical Council has low lay representation, and that's been an issue for debate. Should we have more lay representation? How do we get more lay representation? Another piece of work that Carrie's done that she didn't show today was a survey of the public, asking them, and they have a very high, doctors rate very high in esteem, held in very high esteem in Hong Kong, which is not the same as mainland China.
Well, I was going to ask you about mainland China, because it's...
Mainland China, there are many issues in mainland China. So Hong Kong does have, the doctors are held in high esteem, but people don't actually understand the regulatory mechanism very well when you ask the public.
Okay.
So I suspect that is another piece of work we need to do. But in terms of mainland China, you'll notice there was a tick in the box for CPD. That's because there are big efforts going on to try to improve the quality of doctors, and we haven't got time today to go into the different structures and what does being a doctor mean, because some doctors, particularly in rural areas, don't have very high levels of education. They're more like physicians' assistants. But mainland China, having had a market economy, medicine went into the market economy with Deng Xiaoping. Then you swing back to the new reforms, which began in about 1990-2000. So there's a big reform agenda, which is much more about equity, about making sure that there are better standards. But a lot of the population, with their increasing wealth, are demanding services that they can buy with their wealth. And underlying all of this is the fact that really to have good regulation, I believe you need a good healthcare system. And if your healthcare system is in reform and change, as it is in many parts of Asia, there are many issues that have to be dealt with. And so I think mainland China could best be summed up as looking to examples from well-regulated places and trying to make the changes. I think I'd also point out that the private practice in Asia in primary care is the highest in any part of the world. And where you've got a lot of private practitioners, regulation can be quite complex. And we know that from Hong Kong, but it would be the same in Malaysia or Indonesia or anywhere in Asia, mainland China, where you have individuals working on their own. So you need to be thinking all the time about the healthcare system, how it's organised, and how regulation fits within the reform agenda.
But just picking up on Carrie's research, I mean, you would agree then that in terms of globally, there is a massive movement in terms of the way change is happening in regulation and greater lay involvement.
I think the GMC has really laid down the gauntlet almost in countries that have done very little, particularly the colonial countries, because they had a system that looked all right where government basically played a bigger role, and the GMC's sort of changed. Question, how should we change in other parts of the world? And people, also the greater informed public, someone this morning was talking about patients and the internet. People know much more about medicine. It's much more accessible. Role of doctors is changing in different places. You have to change regulation. And I mean, you've got Harry Caton talking tomorrow. I can see him in the back there. He was in Hong Kong last week talking to us about voluntary registration of other healthcare professions, because some governments are very loath to legislate. And I think Harry will tell you tomorrow that legislation isn't always what it's made out to be. So some professions wish to be regulated, but it is quite complex now being regulated, because you set up boundaries, and if you want team approaches to care, the boundaries of professionalism are quite difficult to define. So I would say that there is, from our work, wherever we went, we found people discussing how to change, even countries who are advanced. I would imagine the GMC is continuing. Neil's nodding at me, so I think I'm right. It's got momentum. It's a movement. And with the world sort of coming together much more, you know, in terms of mobility, in terms of knowledge and information, it's how do we all move together. And for my reading of it is, if we're concerned about patient care, we have to be concerned about equity and inequity. We have to be concerned about distribution. We have to be concerned about standards in remote rural areas as well as in high-tech centres. So the global trend is much more to share information and to find flexible common systems. Now, that's an aspiration in many situations.
Okay. Elsie, if you can finish by telling us about how system of regulation works in Denmark.
Yeah, I will gladly do that, and it's definitely another system, another way. I'm the Director General of what we call the Danish Medicine and Health Authority, and we have like one authority that both authorize, supervise the medical health staff and also make decisions on the sanctions. So we have like one body in all. We can define whether we hear of an incident. It can be through the press, or it can be through data, or it can be through some letters to us, and then we decide whether we will do an investigation on our own. And then, of course, we can decide on the end if it's an organizational risk, or it's a personal risk, or actually if it's an area of risk. And I should say that I'm appointed by the government that was then, but when the government changed, I don't automatically change, but anyway, I'm appointed by the government, and we are run by taxpayers' money.
So state-funded, state organized.
Yeah, we have some supervisory functions that are actually fee-paid, specifically, for instance, on cosmetics, that we'll have to do. So it's written in the law that we will have to do that, and they are applied, you know, they must pay us. But basically, we are paid by tax money.
And how do the doctors regard that system? Because I mean, in Germany, they wouldn't be at all happy.
No, I think we are working well. I mean, we are also working. This goes way back to many centuries, but I mean,
yes,
it's a cultural, historical,
cultural differences that we ought to be aware of, whether it's in Denmark or Singapore or Germany.
I mean, Denmark is a small country. It's 5.5 million in a very flat area, and it's very organized in so many other ways that it's maybe it also comes along with that.
Okay. I can give you the result of that if you can remember what it was. The vote that we had a little while ago. Can you put that up on the screen for me? So Oh, you've got to vote again. Sorry. Would you mind picking up your... Was this the third or the fourth? This is the third. So there's one more after this. So if you can vote there, I'll read it out very quickly in case you can't see. Does your country have multi-professional regulation? No. Single professional regulation? Some. Multi-professional? Yes. Have we voted? Yeah. And can we have the answer, please? Just coming up now. C was yes. There we are. So roughly half, some multi-professional regulation for some but not all health professions, and 30% one body or piece of legislation, and roughly 1 in 5 single professional regulation only. Now we've got one more question. Is your medical regulator financially independent from government? Yes or no? This is a pretty simple one. You may question what you think of financially independent, but anyway, we'll see. If you can vote, please. And the result. Okay, so roughly 2/3 saying yes and roughly 1/3 saying no. Okay. So before I bring in the audience, there's a question I wanted to ask all of you, and Frank, I'll put this to you first of all. If you had a doctor, say, who did something involved in malpractice, as happened in the UK with a doctor who trained in Germany, who struck off in the UK, can you strike him off in Germany?
I can apply to the government to strike him off. I can't do it myself. He has to be a compulsory member of the chamber, and I cannot terminate his membership unless the government withdraws his, what we call approbation, his license to practice.
I'm thinking particularly about the case of Dr. Ubani, which,
yes.
Peter, you might very briefly just give us a 30-second upsum of that.
I mean, in a nutshell, Dr. Ubani came to Britain, spent a night here, killed a patient, went back to Germany. The GMC struck him off the register. He's still practicing in Germany.
How worrying is that for you, Dr. Montgomery?
That's well, of course, the official answer is it's very worrying, but it has to do with a complicated legal system within the European Union. It is not a question whether we cannot strike him off the list. I can only repeat myself there. The government obviously said that he has been punished for his misbehavior or malbehavior in the United Kingdom, and you cannot be punished twice for the same problem. This is according to European law. And we are not very happy with the conduct of this doctor. It happened in a different chamber, not in my personal chamber in Hamburg. It happened in Westphalia. But it is one of the big problems of European regulations. And those of you who are concerned with European regulation realize that with the IMI, the new system of internal market information, we're trying to set up standards how we can inform each other and how we can prevent such things to happen.
I think I'll ask for a vote, but it'll take a little bit of time to organise, but it would be a yes or a no. Would you like to see regulations apply, if a doctor is struck off in one country, to apply internationally, a yes or a no? And we'll... Oh, that's live now. Blimey, that was quick. So, would you? I've got to do the question. So, if a doctor is struck off in one jurisdiction in one country, should that apply internationally? Yes or no? And if you could vote now, please.
Can I ask a question myself?
Your
question is, should that apply?
Frank, just hold on a second. Do my question first. Okay, so 4 out of 5 say yes. Frank, go on.
No, my question, I think your question is misleading because you cannot strike someone off a list in another country automatically. This does not apply with a legal system. This doesn't go with a legal system.
No, I know it doesn't, but we're asking whether it should. We're asking whether it should.
Yeah, but just give this a little thought. There might be countries where abortion is so illegal that a doctor will be struck off the list. If we had an automatic process in all countries, this would be...
Yes, clearly
information
there would be,
is the
yes,
thing.
No,
I think you have to inform the other authority.
Absolutely. I'm not... Clearly there will be cultural things that would be anathema in some countries, but it was a general point. if you have a doctor who behaves in anyone where you'd have a common view that it would be malpractice, that if we had 12 good and honest people there and they would take that view unanimously that that person had behaved in a clear case of malpractice and harmed a patient, should that apply? But I take your point. Can I just, Frank, I'm not trying to have a go at you personally, but I just ask you one more question before I move on about how transparent is the system of self-regulation in Germany when you have these hearings? Can people sit and can the public come and attend?
No. We have no lay involvement in the whole process. We have no public involvement in the whole process. It is public to the profession within the professional bodies, but it is not publicized and we have no lay involvement. But we are, and I forgot to mention that at the beginning, we are supervised by the Federal Minister of Health, but he can only supervise he cannot supervise the content, only the legal process of our conclusions, of our findings. So it is a mere legal supervision of the government over our professional conduct courts.
Do you feel in the sort of 21st century with this, we've heard this huge movement towards more lay involvement, more openness, that is a system which can withstand the desire for change from patients?
Well, we do see a lot of lay involvement in questions of regulating the proceedings afterwards. For instance, in our malpractice courts, we now involve a lot of laymen to help us see the position of patients as well. But in the courts that deal with the professional conduct of a professional doctor, we up to now have no lay involvement. But I do agree that might change in the future.
Okay, before I just want one more question to all four of you before I open it up to questions. Is, you're all dealing with fairly well-resourced, developed countries in terms of your standpoint. Are the principles of the systems that you run, how would we apply those principles to a developing country, or one that is very poorly resourced? Sian, do you want to go there?
I think the concept of leapfrogging comes in here. Everyone else is learning and moving forward. And I think if you actually want to sort of say, can we start afresh? You can say, well, what seems to work best? I find it quite interesting, the whole debate about lay engagement, because I would have thought that would inevitably happen in healthcare systems as they progress. So you might start by wanting to make sure there was lay engagement. I think governments have to be involved at some point of health development, so you can't do it entirely as a professional group because you won't have the resources. If you take some of the sub-Saharan African countries, you just don't have the numbers of people to do it. Then that's when you say, do we have a common register for all professions? Because it makes the most sense. And then you look at... So I think all of these questions are not very easy to give blanket answers to, but I think you can look at what examples you've got in other places and say, how can we get something that fits us? And you mentioned before the culture, that fits our culture. I do think many post-colonial countries will have rudiments of their own colonial systems in the professions. Historically, that's probably a fact. So you need to build on that history. And I think there may be an obligation of those countries that are better off, the developed countries, to assist countries in their development. So I think we should see it as a whole issue of development.
Elsie?
Well, yeah, I mean, I think it is necessary for us, to develop and also to learn, from the mistakes we have sort of also with us in our baggage. And I can see for Denmark now we are really moving away from a more maybe reactive and some proactive investigations, but based in law, because we also had the scandals, and then came a law that specifically said we should go there every second year, every third year, whether there was any expectation of patient safety being at risk, and therefore I think that the movement to have the discussion and to see in other parts of the world, to have the discussion on actually what is the learning process, and I think definitely also to bring the risk into the whole equation, because I think that's where we should also in very well-developed countries use the resources.
Okay, well let's open it to questions from the floor. There are 4 mics. There's a gentleman there who had his hand up very quickly. If you could say who you are, that would be helpful.
Of course, yes. I'm David Gordon, and I'm from the World Federation for Medical Education. And this is a comment on the very interesting opening talk that Carrie gave. And she referred to the way in which many regulatory authorities, many countries, have a list of the institutions in other countries from which graduates might apply to work. We, the World Federation, together with FIMA, are responsible for the development of the World Directory of Medical Schools, which has an objective of listing all the legitimate medical schools in the world. It's the successor to the old WHO World Directory. We and FIMA separately ran directories, and we actually merged them a couple of years ago. John Norsini and I spoke at FIMA, at IAMRA 4 years ago to say that we were going to do this. It's a very, very big task, but a directory of all the medical schools in the world, I think, is of interest to everyone in this room. And it's the kind of thing that if you're engaged and will help us, we'll get as good as we can possibly get it. I'm here from the World Federation. Ask me about it. Amy Opalek is here from FIMA. Where are you, Amy? Amy is over there. Stand up, Amy, so the people know who you are. So if you have any questions over the next couple of days, ask me or Amy, and we can talk about how that develops. Thank you.
Excellent. David, thank you very much indeed. Okay, yes, in the second row here, the mic's coming down to you.
Thank you very much. I'm Leslie Ann Hawthorne from the University of Melbourne, and I'd be very interested perhaps to start with Sir Peter Rubin to comment on the growing global momentum for bilateral and multilateral agreements which aim to facilitate the movement of goods and people, and to facilitate the movement of people often lump regulation and recognition of qualifications in a job lot with selling trade-related goods and services. These are multilateral agreements that are supranational. They're often generically formed, but then applied to multiple fields. And there are major goals being set, for example, in the ASEAN region at the moment around medicine, dentistry and nursing. From the experience of Europe, and perhaps also from Hong Kong, I'd be very interested in your comments about how regulatory bodies can best engage and respond to these challenges.
Okay. Peter.
Are you saying that there would be an agreement that everybody who has graduated from a particular medical school or in a particular country as a job lot without further inquiry would be considered to be fit to practice in a different country? Well, I think that that would be quite a challenge, quite frankly. I mean, we've heard David talk about the directory. Well, for an individual medical school on that directory, there could be very good doctors and others who take our PLAB exam and you wouldn't want them coming near you, quite frankly. And so I think that at the end of the day, medicine is a very personal matter. It is you and your doctor. And we as a regulator have a duty to ensure that you can trust that doctor.
Elsie?
I just want to mention coming from a Scandinavian country, and since we can sort of talk to one another in a Scandinavian language, we actually have good collaboration and try also to inform one another if we have problematic healthcare workers or doctors, and have done that for a long time and try to make the mobility. I can say in Denmark we educate a lot of Norwegian doctors. Unfortunately, they all go home to Norway and work because so they take up a lot of facility in our universities. But anyway, we really have good agreements to that mobility. But that's in a small area of the world and a privileged one, I know. But I mean, yeah, and EU, of course, have other types of legislation.
Frank?
Well, I would just like to mention this. In the European Union, we have with Directive 2005/36 a very strict regulation on the content of the medical education. So there we have a standard within the European Union. But I would like to draw your attention to some other fields, like the negotiations between the European Union and other states and the United States of America on the TTIP contract. This is very dangerous because TTIP will obviously interfere with standards. We have to accept standards and norms within the TTIP negotiations of the United States of America, and this will interfere tremendously with our traditional, with the role which we have as regulators, because there will be a lot less government influence and a lot more arbitration and other influence factors which we cannot even look at just now. So we are very much concerned about the TTIP negotiations, and I think they will interfere with our professional regulation.
Okay, I'd like to invite the doctor in the third row to make a comment, who came to see me at the end of the last session. He's got a very interesting perspective on trying to set up medical regulation in Afghanistan.
Well, thank you very much for giving me that opportunity and time. Yes, actually my observation that we are attending the International Association of Medical Regulation Authorities conference. And indeed, we have representatives from the best of the best, and talking a lot about medical regulations in countries that are well developed. Of course, those countries and those organizations have plenty to say because they've got the experience. But what was sad that we don't have sort of any representative from the majority of the public or patients or the world that do not have medical regulations in their countries, unfortunately. And we were talking how IAMBRA, as an international organization, can develop a team, at least in the future, that we can reach those countries or governments to help them to develop their medical regulation authorities at least. And I was talking about my experience in Afghanistan, that at least I worked there for the last 3 years and as a government advisor, and starting talking even about developing a medical regulation authority or medical council, it was quite difficult. The first challenge was that you are going to police us. Are we going to be monitored and observed by a body, independent body after this, what we are doing? Secondly, talking about medical ethics, I was summoned to the House of Parliament by doctors who complained, and to even the ministry and the presidential palace, that are you saying that doctors do not follow ethics, or we do not have ethics, that you're talking about medical ethics? So these are the attitudes that dominate some parts of the world, unfortunately, in this century that we are talking about the best practice in the world. So I was wondering how IAMBRA can sort of develop a team or a discussion, at least, how the countries or associations or organizations that have developed medical councils can reach to at least neighboring countries or regional countries to help them develop some kind of regulation in their own countries. And I would like to ask a question from the panel. We talked about the single professional agency regulation or multiple professional agency regulations. And from your experience, I wonder, for low-resource countries, which model would work best? I would say, in terms of if you have a single professional regulation authority in a low-resource country, there are some benefits. Of course, it's cheap, it's easier probably, and less time-consuming. But my experience, at least from Afghanistan and some other Asian countries, that medicine is quite doctor-dominated, authoritarian, male-dominated sort of profession. If you have one single sort of regulation authority, it's going to be definitely dominated by doctors. Nurses and midwives and other professionals are going to be staying in their own level as it is at the moment. I would like to ask your experience. What would be your advice in this regard? So thank you.
Thank you very much. So, Peter, advice on whether it should be multi-professional and also just generally in a country that doesn't have effective medical regulation, how can IAMBRA and other developed countries help?
Perhaps I could just pick those two things up together. Neil and I are asked many times each year to advise countries around the world on medical regulation. And we're always aware of the fact that what's right for Britain may not be right anywhere else. But if you go back to the very beginning of the General Medical Council and the Medical Act of 1858, And so what did that actually do? Well, the first thing, it was a very limited and simple act. And what it did was define what a doctor is. And then it said, this is what you need to become what we define as a doctor. It was as simple as that. And our advice would be, never try to run before you can walk. Define what you want in your health professionals. You may not even want to use the word doctor. Define what you want in your health professionals as simply as possible, and then do what the Medical Act did in 1858, which is to bring order from chaos. So at least the public knew that if a doctor was on our register, they had reached a certain minimum standard. And that principle can apply throughout healthcare. The second thing about is it a single profession or not, in a sophisticated, developed, rich country like Britain, my answer would be, if you look at any successful organization in the private sector or the public sector, what do they all have in common? They know what they're meant to be doing, they do it well, they're not distracted into doing anything else. That's what they do. We do medicine. And if we were to say, okay, we're going to do medicine and a bit of chiropractors and osteopaths on the side, it would not be fair on osteopaths and chiropractors, and it would not be fair on doctors either. So in our country, single professional regulation. That is not to say it's right for every other country. And my personal view is that if you're starting from scratch with a blank sheet of paper, there would be a lot to be said for a single integrated regulator, maybe not just for the health professions, but for the organizations within which those health professionals work.
Okay, Sian, would you like to come in?
I think I would just agree with what Peter just said. It depends where you're starting. But if you were to start from scratch, particularly in a low-income country, I think make it as simple as possible, as understandable as possible, and as flexible as possible. Because the health needs of Afghanistan, and I teach my students, and I see the difference in infant mortality rate between Japan and Afghanistan. It is so huge. It's hundreds of times. You know, your major issues are very different. So I think you have to meet the health needs of your population by responding to those health needs, and just take that as a guiding principle. And I think the thing you have to avoid is sort of professional infighting, if at all possible.
Okay, thank you. I'd like to take another question at the back there, please.
John Thomas from the Federation of State Medical Boards. I was surprised and struck by the ease of mobility with physicians within the EU. I know in the US, we've been talking about reciprocity since 1912, and because of the states, their feeling is that they do a better job than the next state as far as evaluating physicians. They would never allow something like reciprocity. And they also see it as a patient protection in the sense that if a physician can practice in any state, but they would have to apply in each and every state that they would like to practice in. And we had an issue with Swango, which you may know. He's a serial killer who went from a few states to state and then ended up in Africa. After that happened, we actually have something called a disciplinary alert service, where anytime there's an action taken against physicians licensed in one state, we notify all the other 70 boards in other states. And we're embarrassed by Patel, but because Patel couldn't go anywhere in the U.S. and had to go to Australia. So my question is, are there any issues around this reciprocity and the ease physicians moving from one country in the EU to another? Have you seen any concerns or issues with that?
Well, we've heard that with Dr. Ubani. Elsie, do you have problems? You've got sort of bilateral agreements with other Scandinavian countries. Does that create problems sometimes?
No, I think it works fine, but as also a member of the EU, and actually we're in a position where we import physicians because we have not really, we have a lot of doctors, but still we are, lacking, and we have although being a small country, we still have a periphery of the country, and we have problems getting doctors there. So we have a lot of EU physicians from all over, mainly maybe from Eastern Europe or the eastern part of EU. And of course we have problems with language because we speak Danish and not many other members. So that's why the Scandinavians are easier, while a Polish physician, it's more complicated, so they'll have to go through a language. But we have a lot of EU citizens being medical doctors in Denmark, and I think, it's better with an EU-trained physician than no physician for the population.
Okay. Let me take another question if I could. There's a... Yes, gentleman there.
Yes, thank you very much. Zain Abdin Karrar from Sudan, President of Sudan Medical Council. A low resource country and council that started in 1955. Got very good basis actually from the post-colonial. I think the debate here has to focus on two things other than the low resource. We work within a constitutional and legal framework which is rather different. We work into a cultural perspective that is sometimes totally diametrically opposite to a number of issues. And as was mentioned in this session, and I'm pleased to hear that, we work within a time framework that cannot compare us to somebody who has started in 1880-something. At the same time, the aspiration of our communities through the internet and the IT and the rest of it, they want us to be like the GMC. Our doctors want us to be like the GMC. Yet when you ask for a lot of support, you don't find it. We cannot actually send people to attend this conference because of the cost. I find it difficult to actually convince the government that reaching out is essential for us. What I am, nevertheless, we were asked actually to go to Afghanistan. And I did go to Kabul, actually. There was a funding from Australia. There is a technical help from Malaysia, the Malaysian Council, and I was there actually trying to represent a council that can be very similar to Afghanistan in the sense of low resource, at the same time, the same cultural background. And I was really surprised, first time me to get there, with the enthusiasm of the doctors to get regulated. And I really would like to ask the panel, can people tolerate other cultural diversities and not insist on them in the sense of a moral pressure? You can judge us morally in a different way. And I can give you an example. Female circumcision. Speak about it as something that the Medical Council has to do. Now, our constitutional representatives chose to side in a hypocritical way with the very fundamentalists within my country and put in a phrase that the severe one is prohibited.
If we could move on briefly to the question.
The minor one is acceptable. Now, as a medical council, I should really punish doctors who are going to practice even this one. Then how can I move into that? Either I go and force the issue and the council will be stopped for 10 or 15 years back. The question is, how can the others help us to go on in a gradual pace rather than trying to ask us to do the best practice that is available now? Thank you.
Okay, well, it's a fairly nuanced question. I mean, if you accept that there are going to be cultural and political differences, how can you advise on improving a system without to allow people to move gradually towards, rather than saying that there's only one way you should do it? I don't know who would like to come in here. Yes, please.
I think that you clearly have to be very sensitive to cultural norms. There's no question of that. And if you look back over the long history now of the GMC, the events that triggered some of our most cataclysmic changes were driven from outside the organization by changes in public expectation and therefore the expectation of politicians. And if the public is not ready for something, then there's little incentive for the medical profession to change itself. Equally, looking back over my profession, my profession has been at its most unhappy over the last 150 years when it's allowed itself to get out of step with public opinion, and then it's found itself having things done to it by the government of the day. And I think so you've got to be culturally sensitive, but the profession has to have the confidence and the awareness to provide leadership to move progressively forward. Never would we say, let's impose a GMC on a developing country, because it wouldn't work.
Okay, before we nearly come up to our hour, I'd just like to get a view from the panel, briefly, the four of you, whether you feel that this sort of global move towards greater lay and patient involvement in regulation, whether that is really unstoppable, and how far might it go? And I'm going to end with you, Peter, and start with you, Elsie.
Yeah, I definitely see that this is a movement that we'll have to take in. It's not only about regulation and supervision, it's all over. I mean, we talk about a healthcare system and trying to remind ourselves that we are there for the patient and not, you know, that they are not troubling us. So I think it is a movement, and we are also discussing it in Denmark. We have not been very good, but we'll have to find ways to do it. But we have a strategy also within my institution that we should always involve somehow lay people. And whether it's 75% or 30%, I think it depends on actually what kind of organization and structure we're talking about. But definitely, yeah, we have to be open. We'll have to be clear for politicians, for public, for patients, and for all medical staff, what we are doing and why we are doing it.
Okay. Sian.
I think it's an unstoppable movement as knowledge becomes more accessible and exchange becomes faster. And I think we need to work with it. But having said that, actually in Hong Kong, we don't have very high level of patient engagement as yet. And so again, that comes back to cultural issues and how medicine's perceived and how medicine performs. And so I think there are some, you know, it's not going to be a same pace everywhere, but it'll be essential to have representation of the public and accountability to the public and transparency in our systems.
Frank?
I can be very brief, global and unstoppable. The problem for us is we must be sure and aware that we don't replace professionalism by publicalism. We have to have some sort of competence. So we have to define the fields where we desperately need public involvement, because the medical profession also needs the repercussion of the public of what they are doing at what stage. But at the same time, we have to accept the asymmetry between the learned professionals and the public persons helping us, aiding us, or guiding us on sort of more basic questions. If we can sort that out in a politically sane and good way, we're on the right path. I sometimes have a feeling we're overdoing it a little bit, and we're doing it too fast.
Okay, Peter?
It's global, it's unstoppable, and on the basis of the GMC experience, it is to be welcomed.
Great, well, thank you all very much indeed. Elsie, Sian, Frank and Peter, really stimulating. We could actually go on for another hour, but I'm conscious that it's time